So initially, we know that if we start the history, started with the HEFT trial, which is valsartan in heart failure, and started with consensus trial, which was with enalapril with the ACE inhibitors, then SALT trial, which is also with the ACE inhibitors ARBs. This is the era of the 80s where these have just come up, and this was an era where the choice for the heart failure treatment was quite limited. Then finally, the beta blocker, which were previously contraindicated, they were found to be useful in heart failure with the coming of the MERIT heart failure and the CIBIS 2 trial. These were the trials where metoprolol and bisoprolol were used, and the Copernicus where heart failure with reduced ejection fraction in post-MI patients were used. So these paved the way for the use of both ACE inhibitors, ARBs, and beta blockers in heart failure. Finally, the mineralocorticoid receptors inhibitors, that is the RAILS trial that came with aldactone, was found to be useful in patients who had ejection fraction less than 40%. There were negative trials all along the way, and which included trials with digoxin, the DIGE trial, and it was found that digoxin stoppage was associated with increased mortality, but otherwise, digoxin did not have much evidence to suggest its use in heart failure. So, with the coming of these trials, it was found that the beta blockers, ACE inhibitors, ARBs, and the mineralocorticoid receptors inhibitors, antagonists, would all be useful in heart failure. And by the time of the turn of the century, these three were the pillars of the management of heart failure with reduced ejection fraction. Then after the 2000, again there was there were consolidation of these drugs. The CHARM trial came. The COMET was head-to-head trial between the carvedilol and metoprolol. Then there was trials where the surgery was also tried, companion trial, and they had various results. Seniors is a trial where beta blocker nebivolol was used in elderly, and it was found to be useful. These all trials they carried on, but there was a gap because these trials were mainly consolidation trial where some was maybe consolidated. The knowledge was consolidated, but new drugs did not come until maybe the emphasis heart failure trial where this empagliflozin was tried in heart failure, and finally the paradigm trial where ARNI was introduced in 2014. So we have come a long way from 80s where ACE inhibitors, ARVs were started, to the late 90s where the beta blockers and MRAs were started, to the 2010s decade where empagliflozin, now dapagliflozin, and finally ARNI has been introduced into the management of heart failure with reduced ejection fraction. Apart from it, there were some surgical trials that were also going on, which included the aneurysectomy trials, the HeartMate trials, the various devices for heart failure, and also the resynchronization therapy or the CRTs that were also used in heart failure, which have some impact on heart failure with the reduced ejection fraction. So paradigm heart failure, as the name suggests, is a path-breaking trial where this ARNI was introduced to this world. It is actually a combination of ARP and the neprilysin inhibitor, and the formula was LCZ696, and it was given in this trial at the dose of 200 milligrams BD. So I'll quickly run through this trial because everybody knows about it. This was a large trial, involved a large amount of patients who had heart failure with reduced ejection fraction, and finally it was found that in comparison to enalapril, it was actually reducing the relative reduction of mortality was up to the tune of 20%. So it was not very surprising for the investigators because nanopratil was a previous molecule that was tried but was rejected because there are a number of side effects in terms of angioedema. So the good results were expected, but the important thing was that this ARNI was tried against the established therapy, that is the nalapil in the management of heart failure with reduced ejection fraction. If we see the relative risk reduction in the mortality, the ARNI produced around 20%, but one must remember that it was tried against a established drug of heart failure rather than a placebo. So now we have five drugs, and if we include adenosine and nitrate combination, which has been tried amongst blacks in the population, the Afro-American population only, where the results they are not spread across the all ethnic groups. But apart from that, if we have the ACE inhibitors, the ARBs, beta blocker, MRAs, and this ARNI, and now we have the SGLT2 inhibitors for the management of heart failure. So after the use of this combination of ARNI, it was found that after 30 days there was significant improvement in the NYHA class also, and the number of patients who were in class 1 is also more. So that is the important effect. It all not only decreases the mortality, it reduces the symptoms, which will have a bearing on the quality of life of these patients. Also, the benefit was seen in all across the subgroup of chronic heart failure. So if we divide it by age or the various risk factors or blood pressure, the benefit of ARNI is always there. It is present in all ethnic subgroups also,